Hello everyone and welcome to today's webinar, Trauma Verification's August Q&A web conference. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You have joined the presentation, listen to your computer speaker system by default. If you'd prefer to join over telephone, just select telephone in the audio pane and the dial-in information will be displayed.
Our web conference today, Tuesday, August 23rd. Just a couple of things to go over. This is our quality trauma staff, Tammy, myself, and Rachel Sanchez. The goal for this webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care started. And a couple of updates. The Orange Book resources for some of you who are new to our process or our webinar, please feel free to use a copy of your Orange Book, or you can download a copy from the website. The website is noted at the bottom of the page. I also want to add a highlight is that we are now providing monthly updates to our trauma centers on clarification document, and we have now instituted a verification change log. So if you do not get a copy of that in my email, please feel free to visit the webpage at any time. There will be another communication going out in 2 weeks, and then after that it will be on a monthly basis. The recording of this webinar will be posted on our webpage, and there is the address there, so feel free to visit that at any time. Disclaimer, all questions are pulled directly from the questions submitted. There have been no edits made to the content or any today's webinar. It's probably because there's a duplicate question or requires more information. Where you will receive an email from myself asking for follow-up, and any unanswered questions to this webinar will be followed up within a week. So the first we're going to talk about is scheduling. I'm going to hand this over to Rachel Sanchez.
Good afternoon, everyone. We'll jump right into the first question, and it's in regards to site visits. The first question, they're asking if you had a consultative review already and then you're asking for your verification review, is the site responsible for addressing all the Orange Book standards? So to answer the first part of the question, yes, definitely. If CDs were cited at your consultation visit, you definitely want to fix them by your verification visit. In fact, at least 6 months prior to the verification visit, all CDs must be implemented, monitored, and tracked through the performance improvement process with good outcome. And just as a side note, this is why it's so important to have your verification visit at least a year later and not any sooner, because you need time to monitor and track the outcome to make sure it's working. And then if it's not, you need time to make changes and then monitor and track it again. So definitely use your consultation visit as a guide to help you pass your verification visit. And so the second part of that question, it says, and compiling with current Orange Book standards. The person, I'm not sure, but it might have meant and be compliant with the current Orange Book standards. And that definitely is, yes, please be current in, with the Orange Book standards. Okay, go on to slide 2. The question is, during chart preparation for VRC review, if a chart meets criteria for more than one category, how do you manage? Well, when this happens, just keep the chart in one category. You could tag and label it as multiple trauma injury, but we ask that you please do not duplicate the charts and place one in each category. Okay. Next slide is about chart review. Do the charts for the reporting year go by admission date or discharge date of the patient? The charts for the reporting year are based on the admission date. Okay. The next question is in regards to backup call schedules. It says, are we required to have copies and or access to backup call schedules for orthopedics and neurosurgery? Or is it sufficient that they tell us they have a backup call schedule? Well, during the site visit, the trauma center is required to demonstrate compliance with all standards. So the answer is yes, the center will need to show documentation such as call schedules, backup call schedules, trauma protocols, administrative commitment letters, and etc. Okay, next we'll move on to general questions.
So let's start this off with, is there a way to code or frame webinars? You know, we got that early on, and we added a data field to the webinar portal to capture the level of the trauma center. I want to talk a little bit about this. So I know there's a lot of nuances to our PRQ, and it's an ongoing process that we're doing with it. We're making revisions on an ongoing basis in real time, so sometimes you'll see a change come through that you didn't expect. But I'm working with the operations team in developing, which we actually developed a PRQ guide, and we're just kind of looking at it and making sure that we have captured everything. So we'll disseminate that to folks when that's ready to go. PRQ challenges. Where is the COT in revising fixes in PRQ? As I mentioned, it's an ongoing basis. It's done in real time, and we are doing the best we can with that. The complexity of the PRQs is that, as many of you know, it's based on the level of the trauma center and the patient population, so we have to be very careful on how we're asking to impact or trigger a CD at your site visits and cause even more confusion. Question about palliative care. PRQ page 23 under ICU is asking about palliative care. Yes, we're asking for trauma patients. Essentially, the PRQ, with the exception of the hospital information section, all responses in the PRQ should be related to your trauma center. Appendices. So we do realize that in the appendices for combined trauma centers, there's not one specific to pediatric. What I can recommend is that you can copy the appendix and just have that available on site. What we're going to do at this end is provide copies of those appendices for you to use as an additional document. But you are correct, there is no additional appendices to just pediatric liaison, so we are going to look into doing that. PRQ for combined adult and pediatric programs. For trauma centers that run their adult and pediatric PI separate, why is there no PRQ or additional spaces to capture that data? As I mentioned, our PRQs were programmed to capture specific data. There may be instances where you need additional fields or additional field to enter data. You can actually do that on a separate document and submit that to us, and we can definitely provide that to the reviewers in the reviewer packet so they have that at the time of the site visit. So currently there's not a specific PRQ for pediatric programs unless it's a standalone level 1 or a standalone level 2 trauma center. Then the PRQ will be programmed to answer or to direct the questions to pediatric care. If the center is combined and is seeking separate verification, we have made revisions to the PRQ to incorporate the pediatric criteria, as I mentioned. So that would be in Chapter 10, but there may be some crossover in additional chapters. So as I mentioned, if there's other areas that you need spacing, you can have that on a separate document. PRQ combined data. So a lot of questions about this. For combined surveys, the payer mix and other such fields, a combo of all patients, peds, and adults. Yes, so the payer mix, so anything in the hospital section where it's Section 2, description, trauma levels, and roles, and Section 10, pediatric surgery, in a combo format, so meaning your adult and your pediatric data. So the only exception to this is Section 2, which is your hospital section where it's your payer mix, and it asks for the beds. We want that data to be about your adult and your pediatric data. In Section 10, we only want, if you're an adult trauma center treating injured children or a combined trauma center, your Section 10 pediatric surgery should just contain your pediatric data. Section 2 should contain both adult and pediatric data, as it says here. Nurses, if you have travel nurses, do you count them in your percentages for certified nurses if they have that certification? Answer is yes. I would include any nurses that are working in your trauma or managing trauma patients, include them in that hold the certificate. So yes, include traveling nurses that hold a certificate in the data tables. PRQ questions, antibiotics administered for patients transferred to us from a hospital, open fracture, time to antibiotics administered given at our hospital. The answer is it is for antibiotics administered from the field or when patient is presented to the emergency department. So again, antibiotics from the field, or if it's unknown, then it would be done from the time the patient was presented to your emergency department. FAST exam. We covered this in a couple of other webinars. Please elaborate on credentialing process and QI process for FAST exams. I do want to say that we currently do not have a standard on FAST exams. There is a question in the PRQ that talks about FAST exams and how that FAST exam, how QI is done at your facility. The credentialing process will be defined by the hospital. How QI is done will vary from trauma centers. For example, the center may upload the FAST exam to the EMR and review for accuracy, completeness, and technique. Feedback can be done in various ways by email or directly through the QPath or any other system the hospital has. Post-traumatic stress disorder. Question came in about screening expectations that's noted in page 89 of the Orange Book, and if it's a expectation during acute phase or inpatient rehab phase. Again, there are no standards around post-traumatic disorder. However, what I would encourage the trauma center to do is develop guidelines on evaluating and treating, managing patients with post-traumatic stress disorder. Sorry. We had a question come in about DOAs, and it's pretty extensive here, but basically what it's asking is, how do we classify DOAs from the verification standpoint, or even from the TQIP standpoint? And dead on arrival will vary from center to center, as many of you know. Defining DOA will be defined by the trauma center or by your state regulations. Tammy, do you have anything additional to add?
Yeah, I'd like to, in regards to TQIP. So I know we often get in the TQIP inbox questions about this, you know, for asking if we define DOA. And, you know, as Molly said, we don't across the trauma quality programs. But one thing that a few of you folks that have been around for a while might remember is there used to be a data definition in the NTDS data dictionary that asked questions about DOA. You know, when did your patient die? You know, was the patient dead on arrival, in the ED, or in the hospital? And there was such, you know, there were findings even back years ago when I was still at the hospital. I remember this being an issue for bad data in that data field, and that we would find patients that have been in the ED for 45 minutes or an hour. We just did away with that a few years after I got here. We did away with that completely. And so there is no place that we define DOA. Now what we do, we did replace that data field with signs of life. And it's funny when you ask the same thing just a little differently, sometimes you get good information. That's exactly what happened. But there is confusion that we do define it, and we just don't. Thank you.
So the next slide is referring to TQIP benchmarking report, and I am going to ask Claire to assist us with information about TQIP.
Hi everyone, I'm Claire Dooms, a program coordinator with TQIP, and just as Molly said, I'm here to answer a few of the TQIP related questions in today's webinar. This first question concerns the TQIP benchmark report. It comes from a Level II trauma center who is in active pursuit of Level II verification. The question, is it a deficiency to not have a TQIP report available during the site survey if you are enrolled? In short, no. Effective January 1st, 2017, the requirement is for all trauma centers to be enrolled in TQIP. If the center is fully enrolled in the program, meaning TQIP, at the time of their visit, but has not yet received a benchmark report, the center will not be cited a deficiency for CD 15-5.
Thank you, Claire.
Welcome.
We'll have you come back a little bit later.
Sounds good.
Okay, so we're going to move on to CD-related questions. So we had a question about transfer guidelines, CD 4-3. Requirement about as a regional trauma system, we have developed guidelines outlining injuries appropriately cared for at our Level 4 and Level 2 facilities. Patients with injuries above their level will be transferred to the appropriate trauma center. With this in place, is there still a need for written agreements that state our Level 2 facility will accept our trauma patients? If the regional transfer, so the answer is no. So if it's a regional transfer agreement that encompasses the names of the trauma centers involved transferring to, that will be acceptable as long as the types of injuries that will be transferred or received, there's no problem having that type of agreement. ATLS for general surgeons. Question about general surgeons on a trauma call panel all have to have taken ATLS once, but only the TPM needs to be current. I think there's some misconceptions out there that the TPM has to be ATLS certified. The requirement for ATLS really is for the general surgeons to have completed the course at least once. The TPM is not required to have ATLS. I do want to touch a little bit about the advanced practice providers who respond and participate in codes and activations. They must be current in ATLS, and we'll talk a little bit about that in a couple of slides. Emergency medicine. Do ED providers need current ATLS or have taken it only once? So more clarification on here. And again, clarifications can be found in our clarification document as well. CD 714, physicians who are board certified or eligible in emergency medicine and work in the emergency department must have taken ATLS once. So we're not asking for we're not asking for ED physicians who are boarded in emergency medicine to be current, just that they've taken it once. CD 715, which is an addendum to that, is physicians who are board certified or eligible in something other than emergency medicine, such as family practice, internal medicine, pediatrics, and who work in the emergency department, they must be current in ATLS. Response times, neurosurgeons and orthopedics. Do surgeons count for the 30-minute rule for specialty neurosurgery and orthopedic surgery patients? The expectation is for the specialist or advanced practice providers or residents for that service to respond when the request is made by the attending surgeon. There must be guidelines for the types of injuries the APPs, advanced practice providers, will respond to and have clear documentation with the attending specialist surgeon on the plan of care. So if the advanced provider or the resident is responding, they must report back and have written documentation with the orthopedic or neuro attending. Chapter 8, is the neurosurgical backup cost schedule required, or is the contingency plan okay for level 2? Must have a published neurotrauma cost schedule with formally arranged contingency plan. So the best method is having a backup cost schedule. If there's no backup cost schedule, then there must be a contingency plan, CD 8-5. The plan must include training, credentialing of the trauma surgeons for initial stabilization. Then they can transfer to the same higher level of care, and that must be monitored through the PIPS process. I do want to add that we are looking inside with this. Right now, the questions are a little obscured, and we're going to go ahead and work on that to make it more clear. Continuation of Chapter 8, neurosurgery. Level 1, 2, and 3 trauma centers. If one neurosurgeon covers 2 centers within the same limited geographic area, there must be a published backup cost schedule. Timely care is provided. So here are some examples of 30-minute response times for patients. Neurosurgery, penetrating injury to head will alter mental state, status TBI with emergent surgical intervention, TBI with emergent EVD monitoring, for orthopedic, fracture with vascular compromise, complex pelvic injuries with limb life threat, multiple open long bone fractures. I put this in here just to give an idea or examples of what would constitute a 30-minute response time for these types of patients. Orthopedic operating room cases. Question is, does this apply only to emergent orthopedic cases or all orthopedic cases? The level was undefined, so I'm just going to answer it as it is in the book. In level 1 and 2 trauma centers, a system must be organized so that musculoskeletal trauma cases can be scheduled without undue delays and not at an inappropriate hour that might conflict with more urgent surgery or other elective procedures. So this is applicable to all orthopedic cases. It's not for any other type, but it's all orthopedic cases. Anesthesia services. For level 2 centers, is a CRNA in-house and anesthesiologist present within 30 minutes sufficient for a level 2 trauma center? Yes. The in-house anesthesia requirements may be fulfilled by senior residents or CRNAs or a certified anesthesiologist assistant. Anesthesiologist assistant, so we put that in there, and it's in the clarification document. The anesthesiologist has 30 minutes to respond from the time notified. So the CRNAs can prep the room, get the patient ready while they're waiting for the anesthesiologist to respond. Operating room team. In the in-house OR, is the in-house OR crew a requirement? And this is for a level 2, and this is a new standard. It's a new change for the level 2s. So basically, an operating room must be adequately staffed and available within 15 minutes at a level 1 and 2 trauma center. The best method to meet this time requirement is by some centers that are tracking this from outside the hospital. If that is the case, if tracking the response time for each of the team members from outside the hospital, you must demonstrate the response time of 15 minutes is met all of the time. There's no variance to this. So I just want to encourage folks that this is, this may be seen as a weakness or potentially a deficiency if all your team members are not present within 15 minutes. ICU coverage. Provide examples to meet the criteria required in trauma to monitor ICU response times, other than intensivist in-house 24/7. So I think what the question is for all levels, the PIPS program must document that timely and appropriate ICU care and coverage are being provided. Coverage can be met by the trauma surgeon, intensivist, or PGY4 or 5 residents. So they can provide coverage in the ICU. For level 2 centers for intensivist coverage, do they need to be in-house 24 hours a day or by telemedicine? There are no standards specific to intensivists. However, if they are used to provide coverage for trauma patients in the ICU, they are expected to meet the same standards as the other surgeons. For example, participate in the internal education process that is case-based learning or paying 16 hours of CME. I know there's a lot of questions about the intensivists, so anyone who's required to meet the same standards. Other specialists. What are the requirements for level 2 and OB? And if you do not have an in-house OB service, level 2 trauma centers must have available OB surgery, CD 1170. Ideally, you want to develop guidelines with a plan of care for the mother and the unborn child, including impending delivery, that may include utilize OB and NICU as part of the trauma team, have specialized equipment, consider transfer agreements for services not available. Slide about advanced practice providers. A lot of questions around this, and it's probably going to continue on for a bit. Can a non-ATLS physician extender participate in the care of an injured patient? Also, can they complete the initial assessment of an injured patient? So I said yes, and I want to clarify that. To clarify, the trauma or emergency medicine advanced practice providers, the APPs, can provide assessment to non-trauma activations such as the consultation tier or the fast track. That is for those centers that have those additional tiers and they're not part of a trauma activation team. They can definitely provide consultation or provide evaluation to the consultation tier and fast track. I do want to say neurosurgery and orthopedic surgery APPs can respond when consulted by the attending, but they're not required to be current in ATLS. Social services, as social services must be available at all times, is it required that there be a person assigned only to the trauma? Types and numbers of trauma program support staff will vary from center to center. This role can be shared within the hospital system. So if you have a social worker that works for another service, they certainly, can cross cover the trauma service as well. I have clear back for some TQIP requirements.
All right, everyone. This next question is a general question related to the TQIP requirement, which is CD 15.5, and fees. So the question, tell us a little bit about the TQIP requirements and fees for level 3 trauma facilities. And this comes from a level 3 center. So effective January 1st, 2017, just to reiterate, all trauma centers seeking verification or re-verification must be enrolled in TQIP. And again, that's CD 15.5. Trauma Quality Program, which is VRC and TQIP, for level 3 centers will be $12,000 per year. So this $12,000 fee covers 12 months of TQIP participation as a level 3 center and 12 months of verification as a level 3 center. Please note that there may be additional fees for any additional reviewers required at your visit, and that more details about those fees are available on our website. This next question, also related to level 3 TQIP. By what point would a level 3 facility in the process of going to a level 2 facility begin to submit to TQIP? Now that's a great question. So a center not currently enrolled in TQIP, they have applied for. So in this case, the hospital should join level 1 and 2 TQIP as they are going for level 2 verification. If you have submitted an application for an ACS consultative or verification visit, you are eligible to begin the process of joining TQIP. If the center is fully enrolled in the program, meaning TQIP, but has not yet received a benchmark report, just to reiterate, the center will not be cited a deficiency for CD 15.5.
Thank you, Claire. I had a question about injury prevention coordinator. It's a hospital within a hospital. We are an adult level 1 and pediatric level 2. We have an injury prevention outreach department. Does the leadership over injury prevention have to be someone from the trauma service office? we integrate all services within them. So the short answer is yes. However, the injury prevention coordinator can be part of a hospital injury prevention department. However, there must be someone assigned to trauma. So, you know, we're seeing this more and more where programs are being integrated. As long as there's someone dedicated to trauma as an injury prevention coordinator, that'll definitely be acceptable. Alcohol screening. This one's a little confusing, and I hope I answer it correctly. If not, please reach out to me. The question is, for SBRT, we use both screening questionnaire and blood alcohol. If the questionnaire scores positive, my response to this is, if the hospital's protocol requires the use of both screening process. So the screening tool is going to depend on what you're using at your facility, and if your protocols require that you use both those screening tools, then we're going to hold you to it, and we're going to want to see that that is done for every admitted patient. Process and provide the review team an example, or at least an answer as to why that's not being done. Research question, does being an author on a book chapter count towards one of the required papers for research? That will not be acceptable. We have to see their names being published. Interventional radiology. What is expected response time for interventional radiologists? Is it tracked from the time of written order or verbal notification? The response time is tracked from when the call is made requesting the service. For monthly meetings, a representative from administration is required. Does it matter which administrator is present? It's a great question. We really don't have any requirements to attend the peer review meeting. Aside from the required attendees, additional staff may attend at the discretion of the trauma medical director and or the trauma program manager. So if you want to have hospital administration attend or your PAs or APPs attend, that will be solely the discretion of the trauma medical director and the trauma program manager. Trauma peer review, has there been clarification on alternate representative to the designated trauma liaison when she cannot make it to meetings? Yes. We have recently implemented this as of, I believe, a month ago, and it is noted in the clarification document. The attendance to the peer review meetings can be met by the respective liaison or a designated representative. The designated representative must be the same person at the monthly meeting, so it just can't change from month to month. It has to be the same designated rep that attends in place of the liaison or with the liaison. It could be either or both. CME, if an MD is board eligible, are they exempt from the CME requirements? We don't exempt anyone unless they're new to the service. With that being said, their CMEs will be prorated. So there is a portion that will be accepted as CME. If they're a new hire to the service or just completed residency, as it says here, their CMEs will be prorated. We are working with the chairs to establish a percentage, and hopefully that will be in the next clarification document if a percentage is established. Question about CME. Could we get some level 3 CME clarification? I thought CMDs at level 3s needed 16 hours or a year of 48 hours. No, level 3 trauma centers are not required to have CMEs. I think that's a misconception. It's ideal, it's desired, but they're not required to be held to the CME requirement. Second part of this question is, one of the challenges in listening to the webinars is that not each slide is applicable to each level. I did talk a little bit about this early on, and that is true. If they're listening to the first webinar, we did not have that data field that defines the level. So going forward, we will make an attempt to answer the questions as they come in. So let me just read this really quickly. Great recommendation. Tables will be provided at the end of the presentation. As mentioned earlier, I will direct my responses to a specific level to avoid confusion. So what I did in answer to this person is I developed some tables that will hopefully assist trauma centers in defining or at least recognizing what requirements are needed and ATLS. Internal education process. Please comment on what types of internal education process meets IEP standards. I did a fair amount of talking about this at the last webinar, and there's some examples. There's more examples in that webinar. So the following 3 slides will provide an overview of IEPs that may be used. The Committee on Trauma's Information Technology Committee developed and launched a survey to capture how trauma centers are doing IEP. Responses will be collated and compiled in the hopes of developing a best practice guideline and resource. I'll talk a little bit about that. So we are working with what we call the InfoTech for short name, and we developed a survey. So if you've received the survey, I encourage you to go ahead and complete that survey. We're collecting data on how trauma centers are doing this because, as you notice, that every webinar talks about IEP. How do we do IEP? What's recognized of an IEP? So we're hoping to collect some data from what trauma centers are currently doing and establish a resource document, if you will, or maybe a repository where trauma centers can just go and just see what other trauma centers are doing. So more to come on that. Here are some ideas of topics of what IEP can constitute. Quality issues identified in your peer review, systems meetings, nursing, physician chart audits, based on regulatory mandates, joint commission, pain assessment, falls, medications, evidence-based practice through journals or national meetings where they come back and disseminate that information, case-based learning that identifies issues through the PIP, must be able to document the activity, and it has to be approved by the trauma medical director. The next one is a should. I know some folks are trying to tie it to an hour of CME, but it's currently a should, and we want to see that be done because this could essentially be a requirement in the next iteration of the book. Internal education program. Question is, what does it look like? So this is also in the manual. It could be in-service, case-based, as I mentioned, educational conferences, grand rounds. I mean, everyone does grand rounds. You can do it based on that. Internal trauma symposia. Many of you have that. In-house publications that's disseminated, as I talked about. That can be based from local conferences or a national conference, even a regional conference. We're not looking for a specific, or I should say, it doesn't, it can fit any idea related to trauma. So it can be any subject matter related to trauma. It does not require CMEs, as I mentioned. Attendance, communication of information must be documented. That's important, and I think that's where most trauma centers are not capturing. So whatever system or platform you're using, whether that be SurveyMonkey, are capturing, you're documenting, and you're and feedback, that is acceptable, and as long as you can demonstrate that to the review team at the time of the site visit, they'll accept that. Here's a quick checklist for you to just use as a guide. Again, as I mentioned, determine what platform or program will be used. SharePoint, SurveyMonkey, the intranet, whatever it is that you have. Define the subject matter. conferences, local, regional, national, peer review articles. They can be done weekly, bi-monthly. Again, this is as needed at your trauma center. Must be able to track participation from members, ability to present the hospital's IEP for the site reviewers, as I mentioned. So here's a table that I put together, and I hope it helps many of you understand what is required for the trauma medical director and liaisons representative criteria. So as you will see, the trauma medical director, this is for level 1, level 2, and level 3. I didn't discriminate. So for trauma medical director, liaisons, emergency medicine, orthopedic, neuro, critical care, anesthesia, radiology, as you can see here, current board certification is required. Level 1 and level 2, as you see here, anesthesia and radiologist, it's only required for 1s and 2s. ATLS, I've done it by 1s or current, as you can see. I do want to say where it has the number 1 and number 2, I'll talk a little bit about that. For number 1, for the emergency medicine, as I previously stated in one of the earlier slides, refer to CD 714. Physicians boarded eligible in emergency medicine only have to have taken ATLS once. Physicians who are boarded in something other like family practice, internal medicine, etc., they have to be current in ATLS. The other trauma panel members, level 1 and level 2 and 3. Again, same table, just a little different. Panel surgeons, physicians, trauma surgeons is also valid for pediatric trauma centers. So I apologize, I did not say pediatric or trauma surgeons there. Panel surgeons, physicians, trauma surgeons, emergency medicine, orthopedic, again, same categories. Current board certification, ATLS, CME, PIPS. This one's a little different because we're talking about CME or an IEP or both. So if you're a trauma center that wants to capture both types of CME, that's acceptable. We just ask that you clearly have that documented and for the site reviewers on site. Again, we're talking about who has to have that currently. Physicians boarded in emergency medicine have taken it once. Those who are not boarded in emergency medicine but are in family practice, internal medicine, they must be current in ATLS. So again, I hope these tables provide, a great tool for you. And that is the end of my presentation, but I have more.
This is Andrea. I'm another of the TQIP program coordinators, and I just wanted to let you guys know that for CE qualification that we will be pulling attendance reports and we'll be emailing out the evaluation to claim CE for this live webinar probably this afternoon, tomorrow at the latest. We always aim for 24 hours. And as Molly said earlier, we will be posting a recording of this. It'll go to the American College of Surgeons YouTube site, and it will be linked on the VRC's resources page, so you can look for that probably within, maybe 3 to 5 business days at the most. I can pass it off to Tammy, who has a few more announcements.
Hey, thanks, Andrea. So, don't mind. I want to let you know that I appreciate your feedback on the surveys. Your feedback is so important to us, and we tweak our education programs, whether it is trauma verification or whether it's TQIP, by your feedback as much as we can. But there's some things we just don't know how to address yet for the VRC trauma verification webinars, and that is a lot of you have made comments about you'd really like the slides in advance, And it is just a case that, seriously, an hour before this webinar, we're still working on slides and just really can barely get it to the operator in time. And so, unfortunately, Verifications also doesn't have a portal like what some of you may know that TQIP has. And we don't have a way just yet to get those out to you. It may be something we can figure out in the future. We'll think about that. And there's just so many questions. And part of the reason why this is such a cool. And again, thank you for the positive comments. I appreciate it. But, Molly's inbox and the COT VRC inbox there's hundreds of questions a week. And if you look at the sent box of everything that anybody's email sends in response, the first part of the email says, "I'm so sorry for the delay," and we're like a month behind in the delay. And so this very thing happened in TQIP with my data quality specialist. And when we started this webinar, it really eliminated a lot of the traffic in that inbox. And I kind of hope it does the same for your sake and Molly's sake, because I know we all feel terrible. I'm so sorry that I'm answering you a month later on your question. And this just gives us an avenue to answer everybody. And a lot of times it's also the case where you might not even know you have a question until you hear somebody else's question and realize there's a different answer than what you were thinking. And so we have some things to work on this, and we'll continue to tweak it, of course. And if there is an urgent question, we certainly just want you to know what is happening with that. And there's another thing. Molly, do you have anything to add? Okay. Molly says no.
Thank you.
So Orange Book. I want to talk to you about something really quick that you're going to be seeing, and I want you all to participate in. So as you know, it took years to revise the Green Book and move it to the Orange Book. And that just took years, and we don't want that to happen again. And so in our PIPS program, we are working on the revisions of the Orange Book, and we have a special work group to do that. We have two, actually. One's called Essential Elements, and those folks decide what chapter is going to be revised next. We're starting with Chapter 16, it looks like, hopefully. And then depending on the chapter, that group will decide who those content experts will be on that group. Of course, there's a core group, and Molly and I both are working with that group, as well as the chapter revisions work group. And that's when, okay, so we're going to revise Chapter 16. So the chapter revisions group is the one that actually does the revisions, that has the content experts. And so before we do any updating, though, and revising, one of the things we would like to have is public comment. And that's where you come in. And so we are working on building surveys for each chapter with an opportunity for you to answer questions and provide comments for each criteria deficiency within the chapter. And so if you go and look at the clarification document and see how many pages that thing is, there's a lot to clarify and a lot for us to work on, right? And that's where we have to start, is with that document. But what's really want your feedback. So we have our nurse partners with STN that are testing these surveys at this time, and we're going to be posting them very soon, and really, really would appreciate your participation.
Claire would like to make an announcement about the
One more announcement. Thanks, everybody.
Hi, everyone. Claire again. I just wanted to give you guys some updates and information about our upcoming TQIP conference. Those of you who are already TQIP centers have probably heard a lot about this, but I just want to reiterate a few things for you guys and, hopefully get you excited to come on out in November. So this year the conference is November 5th through 7th. Our meeting format is a little bit different this year than it has been in previous years. On the 5th, we are starting promptly at 8:30 a.m. in the morning. Those of you who have attended our conference in the past might be used to starting in the afternoon if you have been a TQIP participant for a while. You might be used to us having those pre-conference sessions for new centers in the morning. We just want to make it clear to everyone that we're starting this year for all participants, whether you're a new center, a center in the process of joining. Again, right at 8:30 in the morning, we want to make sure that you guys are able to make your travel plans appropriately. And it's starting on a Saturday this year, so we have a Saturday through Monday schedule, just to keep that in mind. A couple other announcements related to the conference. This year we are pleased to be inviting our Level 3 centers as well to the conference. Those of you who are Level 3 centers have probably heard a little bit about our new Level 3 TQIP program, which just rolled out earlier this summer. So we're really excited to be able to include you guys in our conference this year and, of course, in future years as well. So please do mark your calendars November 5th through 7th. More information about the conference can be found on our website. We'll have a detailed schedule which will list out what sessions are available. A couple highlights really quickly for you. We have our keynote presenter, who is Dr. Wayne Meredith. We have a special general session from trauma survivor Brian Boyle. And then another special general session, which is very topical this year. The session title is Lessons Learned from the Orlando Mass Shooting. So we really encourage you guys, again, to make some room in your calendars for the TQIP conference. And of course, if you have any questions, feel free to contact us at acsTQIPmeeting@facs.org, and we'll be sure to get back to you.
Thank you, trauma verification staff, and thank you, everyone. Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. On behalf, have a great rest of your day.